Welcome to today's webinar. My name is Jose Francisco, Project Manager at the IAS-USA. Today's webinar will be going over prevention of HPV-related anal cancer in persons with HIV. How should we screen, and will vaccines make a difference? I'd like to welcome today's presenter, Dr. Grant Ellsworth, Assistant Professor of Medicine at Weill Cornell Medicine in New York. Welcome, Dr. Ellsworth.
Thank you, Jose, and thank you to IAS-USA for this opportunity to speak to you today. IAS-USA designates this as a live activity, educational activity, and there's 1.25 hours of credit are available. Next slide. And the following credits are also available to those eligible. I want to recognize the supporters for the webinar series listed here. Make this possible. In terms, there are 3 poll questions in the presentation. When the slide with the question appears, a window should pop up allowing you to answer the question. Once the poll closes, you'll be able to see the audience's responses. You can submit questions using the Q&A button at the bottom of the screen, and we'll try to answer as many questions as possible. But apologize if we're not able to get to them all. So this is a first poll. I'm just trying to figure out, based on a lot of the questions that were submitted, it does sound like a fair number of providers don't have access to high resolution anoscopy in their practice. I'm just trying to see what the availability out there is for our participants. So fair number do, 60%, that's great, but also a fair number don't. And we can talk about what those practices may be able to do in terms of screening. Next slide. So I don't have any financial disclosures relevant to this presentation. Next slide. So today we're really going to talk about why anal cancer is an important problem in persons with HIV and why we should consider screening for anal cancer. We're going to review the current guidelines, which are fairly limited due to lack of evidence that anal cancer screening may be an effective strategy. And we'll talk about potentially what could be done to strengthen or improve future guidelines. And then more than half of the presentation is going to focus on HPV vaccination and its role in the prevention of anal cancer and other HPV-related cancers and diseases. Next slide. So start with a question here. All right. Okay, so we'll go over these questions, the answers to these questions as part of the rest of the presentation. We have one more question. Really, this is to test your knowledge of the guidelines and maybe, kind of get a sense of what we need to focus on. All right, excellent. Glad that we're getting a lot of people responding. All right, so let's go ahead and get started. All right, so this graph shows observed anal cancer cases in persons living with HIV. This data comes from states' cancer registries. And as you can see in the blue line, which is persons with HIV, anal cancer rates were initially rising through the late 90s, and they've kind of plateaued through the early 2000s, and then more recently seem to be tapering off. This increase in anal cancer rates was thought to be due to increased survival. Persons living with HIV were now surviving long enough to develop anal cancers. The yellow line, dashed line, is observed anal cancer rates in the general population. You can see here that people with HIV develop anal cancer at much higher rates than the general population. Go ahead and advance. I'm going to superimpose the rates of cervical cancer in the general population. The top line is the rates of cervical cancer prior to widespread cervical cancer screening. Cervical cancer screening has led to an observed decrease in cervical cancer rates in the United States. Again, this is in the general population, not in people with HIV. And you see here that the rates of anal cancer exceed those of cervical cancer even before the onset of widespread cervical cancer screening. Next slide. This is a chart taken from the Anchor study website, which we'll discuss a little bit in the future, but I really like it because it puts cancer rates side by side, including anal cancer at the top there. As you can see, HIV, men who have sex with men with HIV have high rates of anal cancer, maybe as high as rates of prostate or breast cancer, and certainly much higher than other types of cancer. Advance. Here we add in the rates of women with HIV cancer. Again, that rate is higher than current cervical cancer rates. And these are rates in a screened population. Advance. And here I'm highlighting the cancers for which consensus screening guidelines exist. And you can see that there are many cancers that have perhaps lower rates than the rate of anal cancer in persons with HIV that have screening guidelines. Next slide. Here it is in kind of a tabular form. People with HIV have experienced approximately 19 times the rate of anal cancer than the general population. This rate is most high in men who have sex with men. We can't discount women with HIV who experience about 10 times the rate of anal cancer in the general population. The most common question that I've received prior to this presentation from this group was, what about men who have sex with men that don't have HIV? And as you can see here, the incident rate is about 19 per 100,000, which is not dissimilar from the rates in women living with HIV. However, much less is known about these rates probably since state cancer registries don't necessarily capture sexual practices or sexual orientation. Next slide. So this is just a graphic to illustrate. It may not actually be accurate, to illustrate what happens. It takes us from initial HPV infection through to anal high-grade squamous intraepithelial lesions or low-grade intraepithelial lesions onto cancer. So initially a person's exposed to and infected with a high-risk HPV. Continuing infection sets up risk that skin becomes, we'll say, essentially damaged and turns into an anal H-cell or L-cell. And then over time, a small number of these H-cells will turn into cancer. I want to note that the vast majority of HPV infections and squamous intraepithelial lesions will actually resolve due to natural immunity clearing that HPV infection. And we think that the rate at which anal H-cell progresses to anal cancer is perhaps less in people with HIV is less than 1% over a 5-year period in persons with anal H-cell. Advance, please. What really drives this process in people with HIV, particularly certain subgroups, is high rates of HPV exposure, such as in men who have sex with men. And decreased cellular immunity due to the HIV really pushes the continuum towards the right and towards anal cancer. Advance, please. So how do we stop this process? Well, one, advance. We can immunize people so that the initial HPV infection is not established. Two, advance. We can treat anal HSIL. And three, we can enhance cellular immunity in this population. Next slide. This is data from the START study that showed a benefit in those that immediately started ART versus the deferred START ART group. There was a reduction of infection-related cancer of up to 76% in this population. This included cancers, Kaposi sarcoma, EBV-related lymphomas, and HPV-related cancers. A small number of anal cancers were in this group, and the total number was actually 3, but 2 of those occurred in the deferred ART arm. Next slide. This is a model developed on data from the Swiss HIV cohort. And as you can see, similar to that first graph I showed you of rates of anal cancer rates were increasing and more recently have been decreasing. And this is thought to be due to enhanced and better ART coverage. You can see multiple lines in this graph of various screening modalities that may even enhance the reduction in anal cancer rates further. But clearly, effective ART is one strategy to prevent anal cancer in people with HIV. Next slide. So anal cancer screening and prevention, really, we've borrowed this from cervical cancer screening. And the goal really is to identify precancerous areas of the anus and perianus to prevent invasive cancer. We do this by screening with anal cytology, also known as an anal pap smear. So some people would advocate using HPV testing. And I really want to emphasize the utility of a digital anorectal exam in patients to help identify prevalent cancers or potentially HPV-related dysplasia. Once you screen someone in that you're concerned about, you diagnose anal HSIL by performing high-resolution anoscopy with lesion-directed biopsy. And then any HSIL that's identified should be treated with ablation of various forms or topical therapies. Of note, anal cancer is treated with chemotherapy and radiation, and actually there are pretty good outcomes, including with remission rates of up to 60% at 5 years. However, the comorbidities of treating this way are quite high, particularly if you've ever been involved in the care of someone with chronic radiation bronchitis. Next slide. So ideally, we'd identify them before anal cancer develops. So this is probably the next most common question that we've received prior to this presentation. Who should I screen and when should I screen them? Well, given the higher rates of anal cancer in men who have sex with men with HIV, definitely screen that population. Women with HIV, again, have higher rates of anal cancer. And if you look at them in cross-sectional studies, approximately 27% of women screened will have anal HSIL. And traditionally, guidelines in some groups had recommended only screening women with certain risk factors, such as history of receptive anal sex or smoking status. But cohorts have shown, a study of various cohorts have shown that women, even without sexual risk factors, for example, have high rates of anal HSIL. Particularly, you should focus on groups with lower CD4 counts and prior history of AIDS, because they appear to be the group that most often advances to develop anal cancer. In the United States, it's probably reasonable to wait until someone is 35 years old, and this is based on the fact that persons under this age rarely develop anal cancer, and cost-effective analyses suggest that anal cancer screening would be cost-effective after the age of 38. So since nobody can remember a number like that, we just typically round down to age 35. Consider screening symptomatic individuals. What do I mean by symptomatic? These are persons that come to you with bleeding, pain with bowel movements or receptive sex. They have anal warts, they have other palpable lesions, itching, irritation. And then you should consider screening HIV-negative men who have sex with men. Again, less is known about anal cancer incidence in this population. However, they do have higher rates of HSIL and probably higher rates of anal cancer in the general population, and actually may respond better to treatment of anal HSIL. Increasing groups are advocating for the screening of immunosuppressed individuals, such as organ transplant recipients or bone marrow transplant recipients. And then another group is HIV-negative women, particularly in the older age, that have known cervical HPV, HPV-16 infection, because it's been shown that this group can have upwards of 25% of this group can have prevalent HSIL. Next slide. So this is my only slide on guidelines, because really there aren't that many well-established guidelines. The DHSS CDC HIV-MI guidelines, which were updated regularly. The HPV section was last updated in 2019, suggests that a digital anal rectal exam may be useful. And this was touching on a question we did receive again. Should I screen people with anal cytology if I don't have access to HRA? These guidelines suggest no. I would posit there might be, still have a role for anal cytology in this population. I live and work in a state that has its own anal cancer screening guidelines, New York State Department of Health AIDS Institute, that it recently issued new anal cancer screening guidelines. They are useful and interesting to look at, and suggest that you should perform this annually in persons over the age of 35, irrespective of HPV vaccination status. And really, they suggest that this should be a shared decision-making recommendation between a physician and a patient. And this is made on the basis of the lack of evidence that anal cancer screening would reduce anal cancer incidence in this population. There are other multiple guidelines issued by local groups and clinics that are also out there, but there really is not a consensus guideline definitively making the recommendation to perform anal cancer screening in people with HIV. Next slide. So this is the model that we employ here at Weill Cornell Medicine, and is employed by other groups that I work with, and really is kind of the basis of what's being evaluated in the Anchor study. And we'll talk about that a little bit. So really you enter this screening algorithm on the upper left side by taking that annual anal history, including sexual history, a history of the symptoms that we've discussed, bleeding, itching, the irritation, the palpable lesions, the pain, performing an anal cytology, and a digital anal rectal exam. Can't emphasize that enough. Any patient found to have an abnormal anal cytology, an abnormality on DARE, or symptoms should be referred to ideally HRA with biopsies. Anyone with high grade on HRA with biopsies, we typically suggest referring them for treatment, or if your anoscopist is able to perform those treatments yourselves, to ablate those lesions. Depending on the number of lesions, as you get to the bottom there, some patients may require multiple treatments to treat all their lesions. And then we typically follow up patients about 3 to 6 months later This is because there's high rates of HSIL recurrence after treatment. Patients with benign biopsies and a somewhat reassuring anal cytology can be just observed annually. And the reason we keep repeating this is because the cytology has limited performance in detecting HSIL, and there could be newly incident anal HSIL or HPV infection in these populations. Particularly follow people with known HSIL after treatment pretty closely because there are, again, high rates of recurrence after treatment. Next slide. So anal cytology, essentially any abnormal result on anal cytology should be screened further. It does have a pretty good sensitivity for the detection of anal HSIL, up to 93%, but the specificity is lower. This means that if you use this as a screen, you're going to end up referring many people with HIV that don't have anal HSIL, but you're probably going to capture most of the HSIL. Recommendations in terms of performing typically counsel patients not to use an enema prior to cytology and abstain from anal sex for at least 24 to 48 hours. And this is to ensure that there's a high amount of quality cellular material in the anal canal. You need to perform this prior to digital anal rectal exam, or DARE, and HRA to avoid lubricant, as that'll decrease the yield. We, at our site, and a lot of sites that I'm aware of, typically use a moistened polyester swab. However, a cyto brush, as shown here, is probably pretty acceptable. The performance isn't too different. There is something called a tush brush out there, which I have not used. It does seem to have a little bit better performance in terms of obtaining adequate cellular material. The way this is performed is you use your fingers to separate the anal verge, because this is the area of the anus where your patient's going to have the most nerve endings, and they're going to have the most discomfort as you introduce the swab. If you pull that apart, you tend to tolerate this a little better. Insert the swab gently until you feel a little bit of resistance. This is hitting the rectal wall. And then you're going to use a spiral motion, applying circumferential lateral pressure, and withdraw slowly over a period of 10 seconds. I count down inside of my head to make sure that I'm getting adequate exposure to all the mucosa in the anal canal. And then most importantly, now that you've done all this effort to get some cells off the anal wall onto this swab, you really need to agitate it vigorously in your cytologic medium, such as thin prep, for at least 30 seconds to ensure that you have an adequate result. If you really want to see a demonstration of this, Jeff Logan, who's a physician's assistant at Denver Public Health, has posted a video on YouTube that is actually quite short and provides a visual demonstration of how to perform this test. I suggest you might close your office door before viewing, so you don't have to explain anything to your colleagues. Next slide. So a common question we received was about HPV screening, and whether or not we could use high-risk HPV as a screening for anal HSIL. And not much is actually known, other than there's high prevalence of HPV infection in men who have sex with men. So the test may not be that discriminatory. However, since we believe about 70% of anal cancer is due to HPV-16, perhaps the population that screens HPV-16 positive should be more closely followed. In women with HIV, the rates of the prevalence of high-risk HPV is much lower. And in the AMC 084, the prevalence was 41 to 45% in two commonly commercially available HPV assays. These two assays performed comparatively similar to anal cytology in terms of sensitivity, but had much higher specificity and perhaps would result in screening, would have result in screening fewer women that don't have HSIL with HRA. Next slide. We took the data from AMC 084 and the samples and analyzed them using Cepheid Expert HPV. And we're able to show that by utilizing the cycle threshold and HPV genotypes available on that assay, that you could actually optimize the performance of the assay, increase the specificity even further. And you just note there on that second line that the unmodified, off-the-shelf test performs pretty similarly to anal cytology, maybe an alternative in women with HIV. Next slide. However, this is controversial. Again, there's not a great large number, studies with large number of participants showing the benefit of HPV screening. There's problems with inconsistent reimbursement from insurance here in the United States. Medicare and Medicaid don't consistently pay for this. There are some commercial plans that don't consistently pay for this. I understand some institutions just write off this charge, and really more studies are needed. And there might actually be something better than HPV screening. There is some evidence that DNA methylation of both HPV and some host genes are necessary for a person to be at risk for anal cancer and anal HSIL, and these might be alternate screening assays that might perform better. And if you screen only with HPV, you might pick up transient infections that aren't causing anal dysplasia, and essentially false positives that don't really assist you in identifying anal HSIL. I do find HPV screening useful in certain populations, perhaps in patients that continually having kind of lower grade anal cytologies like ASCUS repeatedly, and then when you do HRAs, all you find are benign tissue biopsies, and you want to avoid yet another HRA that's going to show up with benign biopsies. I find that a negative HPV test in that patient is pretty reassuring and allows me to kind of decrease my screening recommendations. And then the other time I find it useful is in the patient population that has anal HPV-16 infection. I tend to follow them more closely. Next slide. So I want to spend a little bit of time on digital anorectal exam. And I think this is very important, particularly for those clinics that don't have adequate access to HRA, because this is something that they can perform to potentially pick up an anal cancer at an earlier stage when it is more treatable, particularly at a very early stage, because superficially invasive anal cancer is only treated with surgery and not with chemoradiation. And the way you perform this is you use the glove finger, not necessarily like the finger in the diagram, with lubricant, and you slowly insert it into the anus until you feel the resistance of the external sphincter. If you apply gentle pressure, you'll eventually feel the sphincter relax, and you're able to advance your finger fully. And really, this is an exam about examining the entire circumference and length of the anal canal and distal rectum. So as you slowly withdraw your finger, you apply gentle lateral pressure and really rotate your finger through the entire 360 degrees of the anal canal. Now, my hand doesn't rotate 360 degrees, so I typically do the right side and then the left side. And then once you've examined the canal with your finger, you really should palpate the perianus. That's 5 centimeters from the anal verge to see if you feel any lumps or bumps that aren't visible there. While you're at it, of course, do a prostate exam in men and assess the pouch of Douglas in women. Next slide, please. So what are you looking for on DARE? Well, cancer is going to feel like a regular lump. You might have focal tenderness. You might feel ulceration of the mucosa even. blood may be present on that glove when you remove it. Early stage cancer may not feel like a lump, but it might feel like thickening or a focal granularity, kind of like someone's thrown down some sand, perhaps. And I'm going to, anecdotally, at our institution, most prevalent anal cancers that were diagnosed by a biopsy on HRA were actually palpable on DARE. Now, if just because you feel a lump, don't write it off as a hemorrhoid, because internal hemorrhoids actually tend not to be very palpable, versus external hemorrhoids, when they can become thrombosed, can be quite firm and hard, and notably tender as well. Internal warts tend to be softer than their highly keratinized external cousins. The one thing that will trip you up is anal papillae, because they tend to kind of roll around into your finger yet feel smooth. And if you're not confident what you're feeling is an anal papilla or a mass that could be a wart, you probably should refer that patient. Now, in symptomatic patients with a normal DARE, you should, these are patients with pain discharge. You should evaluate for other causes of their pain, including STI testing for gonorrhea or chlamydia, repeat the DARE at a later, at a close interval, or refer for HRI, or even just diagnostic anoscopy, because you will pick up disease even on a non-HRA anoscopy. The reference here is actually a link to the International Anal and Neoplasia Society's guidelines on how to perform DARE. It's a quick read and can be quite instructive in those that are not experienced in performing an adequate exam. Next slide, please. So this is an example of a high resolution anoscopy. These aren't the greatest pictures for those that perform this often, but as you can see, there is a somewhat acetyl white lesion in the upper left-hand corner. Those little dark pink reddish dots, those are vessels that are atypical, and this particular lesion, when it was biopsied, was an anal H cell. Advance, please. In addition to acetic acid to turn things white, we apply Lugol's iodine, and normal mucosa will hold on to the iodine, and it'll turn kind of a dark brown, as you see in that lower right corner, while H cells traditionally will stay a little bit yellow, as seen up there on the top. Advance, please. This is another anal H cell. Again, it's in that left upper corner, this is right before this lesion was treated. Advance. And in our institution, we're using electrocautery with a bifurcator to remove the H cell lesions. Some institutions are using infrared coagulation. Whatever you use in terms of ablative therapy, the whole point of this is to destroy that skin that's infected and dysplastic. Topical 5-fluorouracil also is being evaluated for the treatment of these lesions. And that's an anal speculum on the right. I'm not going to focus a lot on this. Please advance. Because really, if you're interested in either improving your HRA skills or learning HRA or bringing HRA to your practice, ENs, as already mentioned, they do have a virtual HRA course that has just gone live. And is available. You can learn HRA essentially from the world's experts. There are live interactive sessions available. And then through some AATCs are providing opportunity for preceptorships. You're welcome to reach out to myself or any of the anchor study sites if you're interested in learning a little bit more as well. Next slide. So in terms of efficacy of screening for anal cancer, again, we don't have any proof that doing any of this reduces the rates of anal cancer, but we do have efficacy data on how effective the treatment of anal H cell is. AMC-076 randomized patients to infrared coagulation, or IRC, versus close monitoring. In this study, patients were followed every 3 months, and those those in the IRC group had all of their HSIL treated with IRC. Now, don't focus too closely on the numbers. It gets a little bit confusing, but IRC did treat 62% of all those lesions, meaning about 38% of those index HSILs or HSIL lesions present at the beginning of the study were persistent or recurrent, at least at 1 year. And what I really want to emphasize here is there's higher rates of occurrence despite treatment of anal HSIL in people with HIV. I also want to focus on the fact that quite a few number of people in the control arm, up to 30%, had spontaneous resolution of HSIL. And this has been seen in other cohorts, such as the Spain cohort in Australia, and really differs from that of treating cervical HSIL, which tends to have higher success rates. Next slide. So the Anchor study is really just aiming to solve this dilemma as whether or not anal cancer screening can effectively reduce the incidence of anal cancer. It's going to screen a lot of persons with HIV, enroll a somewhat smaller number, and then follow, once the study's full enrolled, follow those persons for 5 years and evaluate for anal HSIL. It is randomized. Half the participants entering the study are followed closely. All of their anal HSIL is treated, including incident anal HSIL during the course of the study. And then the active monitoring arm is closely followed. And one couple of questions: do we have any data from the study? And the answer is not yet, but reassuringly, the DSMB continues to recommend that the study continue. Next slide. And here's a map of Anchor study sites. If you live or treat patients near any of these sites, referrals are welcome, and including in Puerto Rico. Next site. So anal cancer screening, my summary is you should perform, if you're going to do it, perform it annually or when a patient develops symptoms. Take an anal history, that's symptoms, sexual risk factors, perform an anal cytology, and most importantly, perform a digital anal rectal exam. Normal findings on any of these three should prompt referral for HRA or at least anoscopy with a colorectal surgeon. Anal HSIL should be ablated or referred to a clinical trial since we don't have evidence, and then follow anybody with anal HSIL closely because there's high rates of recurrence. Next slide. Controversies. Well, anal HSIL is thought to be the precedent lesion to anal cancer, but it is highly prevalent. And most anal HSIL we know will never become cancer. Recurrence persistence of anal HSIL after treatment is the norm. So you got to follow these people closely, and access to quality HRA and treatment of anal HSIL is limited. As you saw, almost 40%, I believe, of persons on this call don't have access to HRA. That is changing slowly. There is a lack of unified guidelines, and again, the lack of efficacy data to say that strategy lowers the rates of anal cancer in this population. Next slide. We're going to shift to HPV vaccination now, and I'm mostly going to focus on anal cancer, but talk about some other sites in the body as well. Next slide. So this is a study of the quadrivalent HPV vaccine in men who have sex with men without HIV. And it's in the slide on the left, this is persons in the study that were naive to the vaccine, the HPV types in the vaccine, that's 6, 11, 16, and 18. And what they were able to show in this randomized placebo-controlled trial is that the vaccine was about 75% effective in preventing the development of anal dysplasia due to vaccine types in this group. If you look on this graph on the right, it's somewhat less effective when you included everybody in the analysis, and this included a number of people who had evidence of prior infection or current infection with one of the vaccine types, where it was about somewhere in the 50 to 60% effective range in preventing anal dysplasia due to vaccine types. Overall, in the HPV naive group, it was about 95% effective in preventing persistent anal infection. Next slide. How about efficacy data in people with HIV? Well, we've been able to show that the vaccine is safe and immunogenic in women, men, children and adolescents with HIV. We've demonstrated long-term immunogenicity in these populations. However, we've noted in these studies that people with HIV develop lower vaccine-specific antibodies compared to people without HIV. Please advance. There have been 2 efficacy trials in older adults with HIV and then in younger men who have sex with men. Next slide. The AMC-072, or Adolescent Trials Network, was a study of the quadrivalent vaccine in this younger MSM population with HIV. In this study, the quadrivalent vaccine was not compared to placebo because I believe at the time, the recommendation had already been made to vaccinate this group, and the investigators did not feel like it would be ethical to have a placebo arm. What they noted is there was high rates of prior exposure, evidence of prior exposure to HIV serologically, and highly prevalent HSIL in this population. And so persons that screened for the study that didn't have HSIL then went on to get the 3-dose series over 6 months. And now the group on the right in the table, this is the group that was seronegative at baseline and HPV DNA negative for one of the vaccine types at 7 months, 1 month after vaccination. And you see in this naive, HPV naive group that there were no incident LSIL or HSIL due to vaccine types in the quadrivalent vaccine. Whereas if you compare it to the group, and this is how they did the analysis, compared it to the group that had evidence of at least infection with one vaccine, prior infection with one of the vaccine types, there was much more anal LSIL or HSIL due to vaccine types in that group. Now, while none of this was statistically significant, probably because there was low rates of at-risk time in the study, it does suggest that the vaccine is more effective in those that are naive than those that have prior exposure to HPV. Next slide. So ACTG 5298 was a randomized placebo-controlled trial of the quadrivalent vaccine versus saline injections. And the outcome in this study was persistent anal HPV, which was defined as detection of HPV at 2 subsequent study visits, or in this first line, or at the last visit. Now, the vaccination group didn't have statistically significant lower rates of persistent infection compared to the saline group. And as you can note on the third line, there wasn't any difference in the rates of anal HSIL in between the 2 groups in the study. In fact, the DSMB for this study actually recommended early discontinuation of the trial due to futility. Advance. I would note, and we're going to discuss this further later, that there was a trend towards protection against oral HPV infection in this group. Next slide, please. How about real-world data of HPV vaccine? Well, we got to go to the cervical world. And this is a nested case control study using cases and controls from the Kaiser Health Network in Northern California that matched over 4,000 cases of cervical HSIL with 21,000 controls. And what they found in this group is that vaccine at a younger age was more protective than women who'd started a vaccine at an older age. In fact, the cutoff seemed to be 21 years old in the study. Advance, please. I'm going to highlight that here. Suggestive that early vaccination is effective and the vaccine efficacy decreases as age increases. This might be probably due to HPV exposure and the onset of sexual activity. The limitations of this study is that, of course, these women haven't been followed out in the long term, but it is suggestive that early vaccine is more important than later vaccine. Next slide. So how did we arrive at this recent FDA change to the indication of the nonavalent or 9-valent vaccine and adding adults up to age 45? Well, the data comes from the Merck trial of the quadrivalent vaccine that was performed in Colombian women, older Colombian women. No, these women had no history of cervical disease or genital warts in the 5 years preceding their entry into the study. And they looked at a combined endpoint of cervical dysplasia, warts, or infection due to one of the quadrivalent types. And in their analysis of seronegative, meaning no prior antibodies to vaccine types, or DNA negative women, meaning women without vaccine types, the vaccine was found to be almost 89% effective in this combined endpoint. If you look at the women that were seropositive at baseline prior to vaccine and DNA negative, vaccine efficacy drops to about 67%. And even in those seropositive individuals, that confidence interval is getting quite wide. This suggests that the vaccine, yeah, is probably pretty effective in a group that's relatively has low exposure to HPV, but in those that have higher exposure, the efficacy decreases. Approval, so I've showed you a lot of quadrivalent data. Approval of the 9-valent vaccine was based on an efficacy study in younger women to prevent cervical dysplasia. Then it was shown to be safe and immunogenic in younger men. And then using a term, something known as immunobridging, the vaccine is assumed to be safe, assumed to be effective on other groups that have been shown to be immunogenic to, say, the similar vaccine, like the quadrivalent vaccine or the 9-valent vaccine itself. Okay, next slide. So the current Advisory Committee on Immunization Practices, this is the US CDC committee, really recommends, based on this data I've shown you, that we focus our vaccination efforts on younger adults, adolescents really, particularly at ages 11 to 12, who, by the way, can be vaccinated effectively with a 2-dose series, which is being evaluated in older populations. And that catch-up vaccination is recommended up to the age of 26. Now, the specific terms from the guidelines is over the age of 27 and older, the vaccination is not routinely recommended. Next, advance, please. And this is word for word from their guidelines. The HPV vaccination does not need to be discussed with most adults aged greater than 26 years. Next slide. And this is based on the multiple reasons. One is some of the data I just showed you, that there is probably evidence that vaccination in older adults is going to be much less effective. And most cost-effective analyses have shown that the cost of mass vaccination of older adults, particularly over the age of 30, is not cost-effective. Whereas a vaccination of adolescents may actually be cost-saving. Next slide. So let's return quickly to the data that I showed you from ACTG 5298 that showed there might be a trend towards preventing oral infection. So in that group, in that study, we noted that there was protection against the 4 types in the vaccine group. And then there's a Costa Rica vaccine trial, which was a randomized controlled trial comparing the bivalent HPV vaccine to hepatitis A vaccine with their control. Noted at study exit that the vaccine efficacy to prevent oral infection due to the 2 vaccine types was 93% in these women. This included a number of older women. Next slide. And then going to NHANES data, you can see here between men and women that vaccinated men and women that have received the quadrivalent vaccine have much lower rates of oral HPV infection due to the vaccine types. I do want to just note here quickly the differences in oral infection rates between men and women. Men tend to have much higher rates of oral HPV infection. In fact, I just saw a study this morning published recently in CID that showed that men tend to have almost 3 times the amount of oral infection as women. Next slide. So why do we care about this? Well, epidemiologically, the rates of oropharyngeal cancer, and the vast majority are due to HPV, now exceed the rates of cervical cancer in the United States, with an inflection point around 2000, occurring around 2010. And even now, the rates of oropharyngeal cancer are increasing. As you know, they're on the right. Advance. Advance again. And this is really concerning because there aren't any accepted screening or prevention modalities for oropharyngeal cancers, particularly because there is no defined precancerous lesion like anal or cervical H cell. Next slide. And this really is a disease of men. It occurs about 5 times more commonly than in women. And in addition to that, men with HIV are even higher risk, which is 2 or 3 times more likely than HIV uninfected men to develop oropharyngeal carcinoma. So with the lack of potential screening, a lack of a mechanism to screen for this type of cancer, really HPV vaccination will be our focus in this disease. Next slide. Now, you may have noted that the 9-valent HPV vaccine is actually currently FDA approved for the prevention of oropharyngeal and other head and neck cancer, but this approval, interestingly enough, is dependent on post-marketing research, which is already underway. So there is a Merck study of HIV unaffected men, ages 20 to 45, that just closed to enrollment earlier this year and this is a randomized placebo-controlled trial of the 9-valent vaccine. And it currently is kind of the observation part of the study. And more importantly, more relevant to us is studies of the 9-valent HPV vaccine to prevent oral HPV infection in people living with HIV. This is men living with HIV 20 to 50 years old in Brazil, Mexico, and Puerto Rico. This is an effort that's being supported by a newly formed clinical trials network through the National Cancer Institute. And this is data to look forward to and may support the vaccination of an older population with HIV. Next slide. So a summary of HPV vaccination is that a vaccination at a younger age is not only likely, I should have just wrote is effective, will be effective in preventing HPV-related disease, including anal cancer. Current ACIP guidelines do not recommend routine HPV vaccination in adults over age 26 because it's not well supported by data and it's not cost effective. I'll discuss this a little further in a minute. And evaluation of the 9-valent HPV vaccine to prevent persistent oropharyngeal infection, and hypothetically preventing oral infection would prevent oropharyngeal cancer in adult men living with HIV and uninfected men is currently underway. Next slide. And really, there is hope that HPV vaccination can eliminate these diseases. This is a modeling study from Australia where there's high rates of HPV vaccination that suggests that the effective end to cervical cancer, meaning less than 4 cases per 100,000 person years, could be targeted by 2034 in that country. Advance. And this is on This is due to differences in vaccine policy put forward by the Australian government, resulting in high rates of HPV vaccination coverage in 15-year-olds, with up to 78% of the female population and 73% of the male population being vaccinated. However, rates in the US are much lower in a similar population, with only 54% of girls by the age of 17 receiving vaccine and 49% of boys. And even now, year over year, these rates are not increasing and may even be falling. And I would advocate that we all become HPV vaccine advocates at an early age. I'm not sure how many pediatricians are on board, or people that take care of younger populations, but really the time to act is in adolescence. Next slide. All right, so I think you get another chance at this question. See how we do. Okay, so let's go ahead. So it looks like most of you chose that rates of anal cancer exceed or approximate other cancers. Some chose that we should only screen certain women, and that some chose anal cancer screening has been shown to reduce the rates of anal cancer. Go ahead and close that. So the correct answer is rates of anal cancer in people with HIV approximate or exceed rates of lung, colon, cervical cancer in the general population. Next slide. And if you remember, among men who have sex with men, rates of anal cancer match or exceed those of colon, lung, and maybe prostate cancer. And among women with HIV, the rates approximate historical cervical cancer rates prior to widespread screening. The reason it's the strategy of screening for anal cancer precursors has not been shown to be effective. That's why the first answer was not correct. And we did show that women tend to have higher rates of anal HSIL, irrespective of sexual risk factors. Next slide. So this is the vaccination question. All right, so the majority got this one correct. And advance, you can go ahead and advance again. Yes, so here again is that summary of the current ACIP guidelines, that we should really focus on that younger population, and that vaccination over the age of 27 is not routinely recommended, and it should be based, and they use the term shared decision making, and suggest that maybe if you find someone that's relatively HPV naive or have had low exposure, it's about to say enter a relationship where they'll have new HPV exposures. One thing they bring up, vaccination makes sense. And let's go ahead and advance to the next slide. So that's the end of the formal end of the lecture. I just want to acknowledge my mentor, Timothy Wilkin, and my other colleagues here at Cornell that have been immense support throughout my career. Anna Giuliano and the Anchor AMC crowd for teaching me how to do HRA, teaching me a lot about HPV and anal cancer prevention. I've got a wonderful team here working on anal cancer, and I'm currently funded by a career development award through my institution, for which I'm immensely grateful. Next slide. So now we're going to get to the questions. It does look like we've got quite a few. I'm going to see what I can do here. Okay, so from the slide from Anchor with the rates of anal cancer and other cancers were the data of other cancers from the general populations or cohorts of people living with HIV, The other cancer rates, including colon cancer and all the lung cancers, were from the general population. In our Ryan White clinic, we screen starting at age 30. The recommendation for age 35, again, is based on that single cost-effective analysis. All cost-effective analysis, I'm not an expert in them, but do make a lot of assumptions about the efficacy of anal cancer screening. Notably, the strategy that is being evaluated in the Anchor study is they're only screening persons over the age of 35. How does the frequency of receptive anal sex play into risk factors opposed to insertive anal sex, mainly referring to HIV? Personally, receptive anal sex is a risk factor. We saw in at least one clinical cohort of women that they still had higher rates of anal HSIL. The receptive anal sex, frequent receptive anal sex, clearly, even if you say treat someone all of their HSIL, they're still going to be at risk for new HPV infections ongoing. So it certainly is a risk factor. Is there some estimate of the number of lives saved as screening is conducted annually for people living with HIV? I don't think we know that quite yet because we don't know how effective screening is. Once we know how many cancer cases we can prevent, I think we can make estimates on how many lives would be saved. Again, anal cancer itself doesn't usually result in mortality. It just is very morbid to treat. Which sample is best to collect HPV testing during the screening process? Thank you. Someone from Kenya is on the line. That's awesome. So you can usually, depending on your lab, you can submit that anal cytology fluid that you've collected for HPV testing as well. They can usually just use an aliquot off of that. Or if you're sending it separately, we usually send it in cytologic media like thin prep or preserved site. Or in terms of anal cancer, I think you had a previous incidence of anal cancer. I think that was a previous question related, does it save lives? And the answer is we still don't know yet. That's Anchor study is going to show us that. Writing from Buffalo, wondering if there's any correlation between patients with history of syphilis, HIV positive and negative and HSIL. There is actually some data suggest that the increased anal HPV infection in the setting of anal sexually transmitted infections. Certainly people with anal STDs are probably at risk for anal HPV infection. I've heard some providers doing self-collection. Have you seen evidence of this method? There is some evidence. I don't personally trust it for anal cytology, but I think would be fine if you're using anal HPV as a method. That there is a small study suggesting that anal cytology, I just don't think you're going to get that swab into enough folds because it is an uncomfortable procedure if you're self-administering. And so I generally don't recommend it. And besides, it's hard, there is actually evidence that you can teach someone to do DARE themselves, but we generally have providers do it at our clinic. Next question, do you routinely screen high-risk HPV in addition to cytology? I don't routinely do it. I really want to make sure that I don't place a financial burden on my patients. So if they do have an insurance carrier that reliably pays for HPV testing, I will use it in certain instances. And these are the people that you keep doing anal cytologies and they keep coming back, ask us that lowest grade of abnormal, and you keep doing HRAs and the biopsies are always benign. If you get a reassuring high-risk HPV test, I tend to maybe push out their observation period a little bit longer or forego HRA if I get another ask of anal cytology. And then some in people that have lots of recurrent disease, I think if you pick up an HPV-16, I tend to focus a little bit more on those people and treat them more aggressively, because we know that HPV-16 is going to cause the vast majority of anal cancer, and frankly, it's and the vast majority of anal HCL recurrence. What's the issue with using a cotton swab, decreased sensitivity? I actually think it has more to do with the processing of the cytopathologic sample, because you'll end up with a lot of fibers in there that make it a little bit more difficult to read, but I'm not entirely sure that's true. We've tried both Dacron swabs and cyto brushes. We prefer cyto brush, and the patients seem to tolerate cyto brush just fine. We moisten the cyto brush. And by the way, when we say moisten, most of us are using tap water, or at least some type of clean water. We moisten the cyto brush prior to collected pap. We tend to do 30 seconds. This has worked well for us. Yeah, cyto brush is pretty good. Like I said, when we look at it, the performance differences aren't that different. You might actually pick up a little bit more cellular material, and whatever your clinic's comfortable with. Like I said, we just have always use the Dacron swabs. Can you comment on anal cancer screening in transgender individuals, HIV positive or negative? Some suggest hormone prescription may increase HPV-associated cancers and potentially require screening in trans patients even if HIV negative. Yeah, I definitely, we see a lot of anal dysplasia in our trans population. I don't know if this is due to gender-affirming hormone therapy or not. And you're right, there is some suggestion. I'm not that familiar with that data, but I know it exists. And definitely, overall, they are a neglected population, and we should focus on them. There are quite a few number of transgender persons in the Anchor study, so we might actually be able to see if there's any kind of subgroup analysis when we get the results. The low specificity of anal cytology assumes that HRA-directed biopsy is an infallible gold standard. Yeah, this is a common accusation. Well, I shouldn't say accusation, it's actually correct. But what if the anoscopist missed the lesion and then the high cell cytology be considered a false positive? Can you comment? Yeah, I agree. So we get a lot of discordance. I shouldn't say it. We occasionally come across discordant cytology where all the biopsies are benign and the cytology is suggests that HCL is present. We typically repeat an HRA on those participants to make on those persons to make sure that we don't miss anything. But again, even in the best hands of the most skilled anoscopists, we're probably going to miss lesions once in a while. Okay, Alex, just to make sure I understood, you're screening all HIV positive patients or just those over age 35? Okay, that's a great question. For asymptomatic individuals, we really don't get aggressive until age 35. Now, if you have a younger person, particularly men who have sex with men who have anal warts or symptoms, I typically am a little more aggressive in screening and treating those persons. Again, we are basing this on some of those cost-effective analysis, but we do know that in persons at least with well-controlled HIV, the anal cancer rate incidence prior to that age is actually quite low. So I don't get too aggressive. Any anesthesia for hypercation of the lesions internally? Yes. We don't sedate our patients. We don't have access to sedation for HRA. They do just fine when we do electrocautery. We do local anesthetic using usually a long-acting anesthetic. However, some patients don't tolerate this. I'm fortunate enough to have colleagues here in the New York area. They're able to take patients to the OR and treat them with sedation for those that have a harder time with the procedure. Do you have any updates as to when we'll have data from the Anchor study? Again, we anticipate we'll be fully enrolled sometime this year, in the coming year. And even then, the plan is to follow that cohort for an additional 5 years. So it might be a little bit of time before we get an answer from the anchor study. Does Dr. Ellsworth recommend HPV vaccination for HIVs up to age 45? I was hoping I'd get this question actually, because seemed like my presentation was a little negative on the vaccination of older adults with HIV. In my mind, it's such a safe vaccine that the only downside is financial. So if you're redirecting clinical resources to vaccinate older adults, you know, the data does suggest that the horse is out of you're shutting the gate and the horse is already out of the barn type of situation. But if it's covered by, say, a patient's insurance or whatnot, and they're strongly wanted, I don't prevent anyone from getting vaccination at an older age, particularly since it might protect against oropharyngeal cancer, but it also isn't my focus when I'm seeing in clinics. There's a million other things that might decrease rates, like smoking cessation, discussions about smoking cessation. All right, I think we're running out of time. We've got a few more questions. Do you recommend women with high-risk cervical HPV variants disclose to sexual partners? Great question. I get it from patients all the time, particularly when I'm relaying results to them. I generally recommend that I don't necessarily tell them they need to disclose their HPV status. This is based on, there's actually pretty good evidence that up to 80% of Americans have had exposure to, of adult Americans have had exposure to HPV in their lifetime. The use of condoms, for example, doesn't seem to be that effective at preventing it. On my patients with HIV, I tend to focus the conversation on, if your partner also has HIV, maybe you should talk about screening or vaccination depending on their age. But in general, I don't necessarily feel it. My personal opinion is you don't need to disclose. So what do you recommend practitioners without access to HRAs? Dare only for screening. Great question, Brittany. I'm glad you asked it, because what I wanted to say is, yes, do dare, because if you can do it, you probably still have access to a colorectal surgeon that's going to be able to find a mass in the anal canal. And I actually think anal cytology is useful in persons, say, that have symptoms. You can't figure out why they have symptoms, their DARE is normal, or even if they have an abnormal DARE, do an anal cytology, and if it's L cell or H cell, you can say, hey, there's HPV in there that might be causing either that lesion or the symptoms. In that sense, maybe not do anal cytology on everybody, but just think about that subgroup where you want to really kind of make a diagnosis of what's causing their symptoms or problem. Would you recommend anal cancer screening HIV negative MSM taking PrEP? Again, this was the most common question I got before the lecture. I kind of do a shared decision-making approach with these patients. I let them know that we actually have very little data on them, that they have high rates of HSIL. I let them know that screening them may actually expose them to procedures and treatments that don't have data to support that it decreases anal cancer rates. But you know, you gotta say, hey, hypothetically, it would decrease your risk for anal cancer. And if they and you decide to proceed together, that's when I do. And again, you really gotta start thinking about an older population. Younger patients probably aren't as at risk. Vaccination secondary prevention has been suggested after treatment at HSIL. What is your opinion? Great question. There's actually a recent study out of South Africa of women with HIV undergoing LEAP for cervical HSIL that was randomized quadrivalent versus placebo. Didn't show any difference. And the AMC has a study ongoing for similar study of the 9-valent vaccine and for cervical HSIL in South Africa that's in sub-Saharan Africa that's ongoing. So we might get some more answer there. Jose, are we good to keep going, or do you want us to stop?
Yeah, yes, Dr. Ellsworth, you're free to continue addressing questions if you have the time.
Yeah, I got a few more minutes, so if whoever wants to stay on the line, I know you're all busy, I'm happy to keep going. Where do you stand on allowing patients to self-administer anal pap tests? I am of the opinion, because really to get that swab into all the folds and expose that swab to this anal mucosa that a provider's got to do it. There is limited data that the anal self-administered PAPs might be okay. I think it's a little bit different than doing a chlamydia gonorrhea swab on yourself. Can repeated HRA cause future issues? I don't necessarily think future issues. Certainly, treating large areas of the anus can, create an open wound that can then heal into a fistula. I mean, that is a theoretical risk. They're treating large areas of the anus can maybe cause anal strictures, but that just seems to be unproven. The one thing I want to note is some patients just do not tolerate HRA. And whether it's a history of sexual trauma, deep-seated anxiety about the procedure, it really can be a difficult procedure and can be quite almost harmful to some patients. What about sexual for establishing priorities, for instance, MSM that don't have receptive anal sex to be screened? The rates of anal HSIL and MSM are so high that I think even in those that are quote unquote tops, probably should be screened. I wouldn't necessarily focus on it. And like I said, in at least one cohort of HIV, women with HIV, that history of anal receptive sex didn't seem to make a difference. Yvonne says we use Xanax or Valium depending on the patient what she's referring to is patients that have difficulty tolerating HRA. Sometimes we give a couple of doses of Ativan or some other benzodiazepine, and it can be magical for some patients to help them tolerate the procedure. Are there other options besides other than ablation? Yes, there is topical therapies. Some people use trichloroacetic acid that's applied by a provider. There's 5-fluorouracil that's been topically used since the 60s for the treatment of HSIL. These are patient-applied treatments. Some people use imiquimod, although I think, and there is a study evaluating topical therapy, AMC-088, that's still ongoing. We do use some of that. If you take the Ian's course, they do talk about those therapies, and there are published dosing regimens available out there. Sorry if I missed it and discussed it. Is there any evidence using vaccine as immunotherapy in people already diagnosed with anal cancer or reduced of relapse? So in terms of reducing relapse, again, we have to kind of borrow from the cervical HSIL world. There's that one study of 260 women, I can get the number wrong, 200 some odd women that didn't show that the prophylactic vaccine, the quadrivalent vaccine, reduced recurrence. There are newer almost immunotherapy vaccines like DNA plasmid vaccines that are in clinical trials have shown some promise in HIV and unaffected women for cervical HSIL that are being currently evaluated in people with HIV. So keep your eyes peeled. I'm particularly myself, I'm wondering if an mRNA HPV vaccine would have better effects than the current protein adjuvant vaccine. Time may tell, and in the future, I hope that we have better immunotherapies. Is there any data or have you observed any correlation between the frequency of either HSIL or precancerous, cancerous development, nadir CD4 and AIDS diagnosis, length of infection, et cetera? So in terms of length of, I'm guessing length of infection refers to how long a person has had HIV. I'm not so sure, but definitely AIDS and low CD4 counts have been shown in multiple kind of retrospective studies to have higher rates of development of anal cancer. Anecdotally, the persons with low CD4 counts do tend to respond poorly to treatment and seem to have higher rates of recurrence, higher numbers of lesions, including more warts and things like that. So I think that's where, as providers, maybe that don't treat anal high grade can really focus on making sure that there's good ART and HIV viral suppression in place. Okay, one last question, and I think I'm gonna go. I'll cut off for low CD4. People have used 500 and 200, I guess, Jeb. Anybody below 200, I really tend to focus closely on getting them on HIV, on ART, and to screening them regularly. Melissa, who is an anoscopist, great. Curious if you use HPV vaccine for people with HIV with persistent HPV on HR exam, not responding to ablation, topical therapies. I don't, and I think that's mostly based on the studies we have thus far in cervical HSIL, and from particularly from that ACPG 5298 study, it just doesn't seem to make that big of a difference once someone's already infected. I know anecdotally, I have colleagues that will tell you that there's. All right. Thank you,
Dr.
everyone.
Ellsworth. Evaluations and information on how to claim continuing education credits will be emailed by 5 p.m. Pacific time tomorrow, and this will enable us to review all of those that have attended today's live broadcast. Here is a list of upcoming webinars available for sign up, and for additional information, please visit the IAS-USA website. A new IAS-USA website feature, Practice Question of the Week, is now available to help our audience stay informed of state-of-the-art practices for prevention, treatment, and care for people with HIV and COVID-19 and other viral infections. This was the response from last week's Practice Question of the Week, and these show up as a pop-up when you visit the IAS-USA website and can also be accessed on the resources page. Save the date for the 2021 annual Ryan White HIV/AIDS Program Clinical Conference, which will be taking place from Sunday, October 3rd to Wednesday, October 6th. Here is a list of on-demand dialogues that are available on our website. Please keep in mind that COVID-19 information changes rapidly, and the webcast and podcast formats have a limited shelf life. Lastly, we'd like to thank our presenter, Dr. Ellsworth. And this concludes today's presentation.